Hi, it's Dr. Helen again. So some specific questions that I had come in about allergy testing. Is there a right to get both blood test and skin prick test done? Because in the US, tracking specific and component IgE levels over a period of time is widely practiced, but in the UK it does vary from allergy clinic to allergy clinic. So you're right, practice between allergy clinics is different. Generally, if you've ever been to a doctor, you will probably have found that quite often you get different management approaches from different doctors, and allergy is no different from that, in that people may interpret papers differently, have different ways that they found work for them. And it's one of the frustrations of being a patient, really, is that you can get stuck in the middle of different people saying different things. As long as people are following guidelines, then to some extent that's okay. Is there a right to ask for things? I guess you can't, as a patient, you can't demand that anything is done. So usually, working in a children's clinic, when people used to come and see us, more often than not, we would do a skin prick test. And if that was positive and we had that clear history of allergy, then we wouldn't go on and do a blood test, partly because you don't want to put the child through an unnecessary blood test when it's not actually going to add anything. It isn't going to add very much to know what's that specific IgE in the blood when we have a skin prick test that's positive anyway. So we would usually use the skin prick test to track the allergy, and if the skin prick tests then are negative, we would do a blood test then to confirm that that was also negative before we went on to do the hospital food challenge. But we wouldn't routinely do both. If you really were desperate to have the blood test done, I think it's just having that conversation, as is important in any field of medicine, of like, why is it important to you? What do you feel it may add? And most of us would be like, well, if you really feel it's important to you, then more than likely we would go on and do it, as long as we didn't feel it was going to distress your child too much. But it's just about having an open conversation, but understanding that it isn't actually going to change our management, and that may be why the answer is no. As I said in my previous video, really because of limitations on clinic appointments in allergy, then generally you're going to expect that for anything other than egg and milk, we're only going to see you every 2 years or so, or sometimes every 3 years, and do the blood test that way. Somebody's asked me, given that you have to wait 2 or 3 years between appointments, could you ask your GP to do the bloods? You can, and if the GP did that and the blood tests were coming back as negative, it would just be then vital that you communicate with the allergy clinic to find out what they want you to do as the next steps. As a GP without the experience, I wouldn't then be recommending that you tell that person to introduce those foods back into that diet just because the IgE is negative. There's usually more to it to decide when the right time is that we introduce the foods. However, having said that, you may well again find that your GP is reluctant to organise the blood test because these things do cost money. That's impacting on the NHS. The GP may not feel they have the skill sets to interpret it, and they may kind of feel that, well, look, if the specialist hasn't said that I need to do it, I'm not sure I do. As working as a GP, it's actually a question that I don't get very, in fact, I can't think I've ever been asked to do it in between clinic appointments. So most of my patients must have been happy with the explanation or happy to wait. If they're not, I guess some of them do go privately and have it done. And therefore, what I'm saying is that because it's not a request that we get very often, if you really felt it was important to you and you had a good relationship with your GP, they may well do it for you. So again, it's just asking and seeing, but understanding that there are reasons on both sides why we do and don't do these things. Somebody said, I'm allergic to garlic, but my blood test is negative. How come? So if you've watched the previous video, I've said that sometimes people are allergic to things and their allergy blood tests and skin prick tests come back negative. Can't really explain why that is. And if we felt that you had a really clear history of a reaction, it might be that we either just say, look, I think you are, then don't eat it, and we will recheck in time. Or it might be that we say, let's do a food challenge to know one way or another if you aren't. Garlic's a tricky one as to knowing whether or not somebody would do a food challenge for that, because it's not actually easily avoidable, so it depends on what the reaction. The other point would be, what is the reaction that you're describing? is the reaction that of a clear IgE mediated allergy. So rapid onset, resolves quickly, happens every time you eat garlic with very classical signs and symptoms? If so, then you just may not have a positive test. Or are you describing something a little bit harder to put your finger on that may not be an allergy? It may be an intolerance, and that may be why you're not having those positive tests. And I just want to touch upon the true definition of intolerance here, because a lot of people, if you say, well, it's not allergy, feel a bit, I don't know what the right reason is, but maybe a bit concerned and almost a bit upset that you've said it's not allergy. And I think that's because as human beings, we want an answer to why we have our symptoms. And sometimes it's easier to hear your diagnosis of it's allergy or it's asthma or it's diabetes, so that you know why you feel the way you feel. It's much harder when you're left going, well, why do I feel this way? So allergy is really clearly defined. We can tell from the way that the immune system reacts if it's IgE allergy. It gives you very clear patterns of signs and symptoms that come quickly and go quickly, and they're reproducible. Non-IgE allergy is much harder to diagnose. It tends to, on the whole, occur in little ones, in infants, but there are some rarer forms of non-IgE allergy that affect older children and adults as well. And the tests for them, well, there is no test for most of them. They are about pattern recognition, about trialling without the food, seeing if your symptoms get better, and then putting the food back into your diet. And if your symptoms all resolve, then we say, okay, then it's probably a non-IgE allergy. So it's quite hard. So my questions would be, is the concern around allergy more of a non-IgE? The true definition for intolerance is a reproducible adverse reaction to food. Now, people often don't like hearing the word intolerant, because in today's society, we use it in a really dismissive manner. We're just like, oh, little Johnny, he's intolerant to everything. And actually, the true definition of it is an adverse reaction, so an unpleasant reaction that occurs every time you eat the food, i.e. we do genuinely believe that perhaps when you eat garlic that you can't tolerate it. And sometimes we can tell you what that reaction is. So it's a reaction that's occurring without that established immunological mechanism, i.e. it's not where the immune system has gone wrong. That's what allergy is, where the immune system's gone wrong. So for instance, people with a lactose intolerance don't produce the lactase enzyme. And therefore, every time they have food in it that contains lactose, they get tummy pain, bloating, diarrhea. And we can tell them that's because you haven't got the lactase enzyme. For other intolerances, I can't tell you the mechanism. We can't always tell you the mechanism, but it's saying, look, we do believe that you can't eat it, but maybe your tests are negative because it's not allergy. And when it's not allergy, then it doesn't carry the risks of anaphylaxis. But I wouldn't be able to do that without exploring the history, but hopefully that helps. But as I say, sometimes you do get falsely negative tests, and then that needs to be discussed more with somebody who understands that to explain to you whether or not they feel that it is truly an allergy, or whether it's an intolerance, or whether it's something else instead. Somebody's asked, how often should we be testing children? They have a child with pistachio and a cashew nut allergy who's 1.5, and generally most clinics are going to see them every 2 years. Food allergies do change quite quickly in those first 5 years of life, particularly milk and egg allergies resolve quite quickly, so we would often test children about those every year. But if you have a peanut allergy at 2, then we're generally not going to see you for a couple of years, unless we had concerns about are things going to change quickly? Is it likely you might have more allergies? Do you seem like a high risk individual because you've got strong eczema as well, or have you got asthma developing, or are there other factors at play that might mean that we want to see you more regularly in an allergy service? The other thing to say is that if your child may have a food allergy, but nothing else, so no other what we call atopic conditions, so no eczema, no asthma developing, no allergic rhinoconjunctivitis, which is essentially hay fever type symptoms, but to anything that's in the environment, so cat, dog, pollen, molds, dust. Then if you don't have any of those things, and say you've literally just got a kiwi allergy, it might be that some allergy clinics see you, that child, maybe once at 6, and say, yes, confirm it on a blood test, they've got a kiwi allergy. And it might be that they see them once more, And if it's stable and nothing's changing, they may well then be discharged from the allergy service, and as a GP you might be asked to kind of monitor them. And often then things are only re-evaluated if the parent felt something might have changed, because either they're starting to have more allergic reactions, or maybe they accidentally had kiwi without a problem. Likewise, for adults, it's not unusual that you would be referred to an adult allergy clinic. You might have the diagnosis made of your food allergies and then often discharged, because things are not likely to change. For many food allergies, once you kind of get to adulthood, you're not likely to outgrow them. So unless something is changing, then often they're discharged from the service with kind of management and follow-up left to GPs, which is not always ideal, because I'm sure many people know that the training that we receive in general practice is often fairly poor. And so whilst you get some GPs who are amazing and know lots about allergies, that's often people like me who were interested in allergies specifically and went on and trained. So if you have concerns and you need help, then either ask to see an allergist again, or the other really useful places to go are the two charities, so the Anaphylaxis campaign, of which I'm a trustee for, or Allergy UK. They have amazing fact sheets, they have support groups, and also they have a health advisor on the end of the phone who knows about allergy. And if you ring them and ask them a question and they don't know the answer, then they have a panel of people like me or consultants that they can ask for the information to help feedback and gain that support. Finally, because somebody asked me about component testing, I'll just touch upon that. It's a bit complex, and even within general practice I often don't teach people particularly about it. But when we're looking on blood tests, we are looking at specific IgE of something, say like peanut. And then within peanuts, there are different types of proteins, storage proteins, that you can be allergic to. And you can sometimes see which of those are you likely to be allergic to and which of you aren't. So for instance, within peanut, there are several you can test, like ARA-H2 and ARA-H8. And if we were not sure about whether you had a true peanut allergy or whether something else is going on, and that often is for people who maybe are allergic to pollen, who can get this unusual syndrome, well, it's not unusual, it's actually very common, called pollen food syndrome, then we might want to work out, are you truly allergic to peanuts, or is this reaction only being triggered because you've actually got hay fever? And so we might look at the components within the peanut, and we might see that if you tested positive to ARA-H2, it's likely that you actually do have a true peanut allergy, and that carries with it the risk of anaphylaxis, so we're going to be saying definitely don't eat it. Versus if you just tested positive for ARA-H8, which we would say great, then it might suggest that you have pollen food syndrome. We're still going to say don't eat it, but it carries with it much lesser risk of anaphylaxis. Now that is complex and inaccurate, so although it's used as a guide, it doesn't tell us 100% whether you have pollen food syndrome or whether you have a true allergy, and isn't needed to be done on everybody with nut allergies. There are specific things within the history that would make us concerned. So doing component testing is only going to be done by allergists, and generally only once, to help us determine what the issues are. It's not going to be something that we track over time. The other thing that you can check for on bloods is something called total IgE, which tells you about what is the level of your IgE totally in the blood. And again, as a GP, there's really often very little point in doing that. I've had lots of referrals through saying this patient's total IgE is really high. Why? And it will be high if you have any of what we call these atopic conditions. So if you have eczema, asthma, hay fever, food allergies, it's going to be high. If you have some of these rarer syndromes called a mast cell disorder, which is quite rare, your IgE is going to be thousands and thousands and thousands. So, and you're going to have very specific symptoms with that. So we would use IgEs for people like that. But for most people with food allergies, testing a total IgE has no relevance to us at all. So it's not really something that we would normally do. So you can see that testing is quite complex and does need to be done by somebody who knows what they're looking at and what they're interpreting. But it does give you nice answers, but not always. I guess the only other thing that it might be worth touching upon is blood tests and skin tests to look for things called aeroallergens. So these things are in the air that tend to trigger these hay fever type symptoms. So commonly we do it to grass pollen, tree pollen, molds, cat, dog, horse, all those types of animals. And it could be that you give me a history that every time you're near your cat, you sneeze, your eyes run, you might get some breathing difficulties, and yet your blood test, your IgE to cat is negative. That's not unusual. So then more often than not, we would need a skin prick test to see. And most of the time, that is going to be positive if you're allergic. But sometimes some people aren't, and yet they're giving you really clear history that they're allergic to these animals. And there are specialist centres in London that will look more locally at the IgE produced in the nose and then find that that is high when provoked by things like cat. It's just one of those things that sometimes you do get negative results, but actually the history fits with allergy. So people need to be very careful about why you order tests and how you interpret it. And that's why I often tell my colleagues, only do it in conjunction with a good history. And if you're not getting the answers you were expecting, then ask for help. I hope that's helpful. If you have any more questions, then please pop them down below and I'll see if I can answer. Thank you.